My name is Dr. Rob Beattie. I'm an orthopedic surgeon at Northwestern Medical Center, and I specialize in hips, knees, and shoulders. I'd like to talk to you today about hip arthroscopy. You've been diagnosed with a condition that may benefit from hip arthroscopy. I will discuss specifics of your personal diagnosis and your surgical management separately, but I wanted to go over with you in general terms the process of hip arthroscopy. This will just take a few minutes of your time to explain some of the history, how the procedure is performed, the different possible procedures, post-operative restrictions and weight bearing, potential risks and complications, and expectations for outcome. Hip arthroscopy is considered a minimally invasive procedure. It involves small portals and the use of an arthroscope, which is like a small telescope attached to a video camera, so that everyone in the room can see the pathology and the procedure in order to assist me at surgery. Arthroscopy was initially applied to the knee, but subsequently to the shoulder and then to other joints. The popularity of hip arthroscopy was delayed due to the fact that the hip is buried deep within a thick muscular envelope of soft tissue. It is a relatively constrained joint, which makes access more difficult. However, there have been multiple technological improvements that have increased our ability to safely and effectively access the hip joint and to treat problems inside the joint. Although the success rate for knee arthroscopy tends to be in the 90s or 90% range, for shoulder arthroscopy in the 80s, the success rate for hip arthroscopy tends to be in about 70 to 75% range. This does vary depending on the procedure. Unfortunately, the hip does not enjoy the same high success rate as knee and shoulder arthroscopy, but nonetheless can be very effective. Hip arthroscopy also usually takes quite a bit longer to perform, and it may take a few hours to address all of the elements of the problem we're treating. From an anesthetic perspective, it is typically performed under general anesthesia with full muscle relaxation. It can be performed with a combination of spinal and/or general anesthesia. In order to access the joint, it is necessary to use a specialized hip arthroscopy table. We use padded boots similar to ski boots, which are applied to both feet, and we use a very large padded perineal post, which allows us to apply traction to distract the hip joint. And we need to distract about 1 centimeter in order to be able to gain access to the joint. A C-arm, or portable X-ray machine, is brought in from the opposite side, and this allows us to visualize the amount of distraction that we've obtained, and the traction required may be as much as 50 or even 75 pounds in order to gain access to the joint. The amount of traction is dependent upon the size of the patient, the stiffness of the joint, and the specific pathology that we're treating. Once we can see that there's enough distraction, a spinal needle is advanced into the joint, and then we remove the stylets, pass a nitinol needle down the spinal needle into the joint, and then remove the spinal needle itself, leaving the guide wire in place, and use a cannulated dilator in order to dilate a track into the joint. A cannula is placed over the dilator, and the dilator removed and the arthroscope introduced into the joint through the cannula. This allows for initial inspection of the joint. We use a 70-degree arthroscope. Rather than straight on, it allows you to look around the corner, and this extends our available field of view. We then use both the arthroscope and the C-arm from the other side of the table to guide the placement of a second spinal needle so that we can be sure that we're entering at the appropriate location. And we use the same technique with the nitinol guide wire, the dilator, and the cannula placement. We always use at least 2 portals, but usually 3 or 4 portals are required for hip arthroscopy. There are a number of different procedures that can be performed. The simple ones would include debridement, which is the trimming of a torn labrum, removal of a loose cartilage, essentially anything that may cause clicking, catching, or pain. Loose body removal is also relatively straightforward as long as you can access it, and sometimes it can be challenging getting around the curvature of the femoral head. Synovectomy is the removal of inflamed synovium. The synovium is the lining of the joint, and when it's inflamed, it can cause pain, so this can be removed. Acetabuloplasty, first of all, the acetabulum is the cup or the socket of the hip, and there can be an overcoverage or bony prominence of the edge or margin of the cup, and this can cause impingement. When there's overcoverage, it's called a pincer lesion. And acetabuloplasty is where we remove that bony prominence at the margin of the cup in order to decrease impingement. Proximal femoral osteoplasty, proximal is upper, femoral is the thigh bone, osteoplasty is the contouring of the bone. So a proximal femoral osteoplasty is excision of a bony prominence. And if the head is not spherical and there's a prominence, it can impinge as the hip is taken through range of motion. By removing the prominence and creating a nice spherical contour, we can decrease impingement. That asphericity or prominence can cause damage to the labrum and the articular surface cartilage that lead to pain and secondary arthritis. If the labrum is torn, whenever possible, we repair it. The only time we don't repair it is if it's so badly damaged or degenerative, or if it's so small or calcified that it isn't reparable, and then the labrum would be debrided. In certain situations, it's necessary to use a graft to reconstruct the deficient labrum. Finally, when there's an area of exposed bone, we may need to resort to what's called microfracture. When the articular surface cartilage has a defect down to bone, we make multiple small penetrations into the bone to encourage access of the bone marrow, because the bone marrow has what are called pluripotential stem cells. These are cells that have the ability to differentiate down different cell lines. And post-operatively, when you're going through range of motion, the cells recognize that motion and tend to differentiate into cartilage cells, and they produce a cartilage-like repair tissue rather than a fibrous scar tissue. Now, post-operatively, the management is dependent upon the specifics of the hip arthroscopy procedure that you have. After the simple debridement or loose body removal or the synovectomy, which is the trimming of the lining, weight bearing is allowed to progress promptly as tolerated or as symptoms allow. However, more commonly after hip arthroscopy, when we do labral repair or bony decompression of the cup or bony decompression of the femoral head, you're then on touchdown weight bearing for the first 2 weeks. This is followed by light partial weight bearing for 2 weeks, followed by moderate partial weight bearing for 2 weeks, and then by 6 weeks post-operatively, you're able to be full weight bearing. The only procedure that lasts longer is the microfracture procedure, where post-operatively you're on crutches, touchdown weight bearing for 6 weeks, then partial weight bearing for 2 weeks for a total of 8 weeks on crutches. So you can see there is a variability in the period of time on crutches post-operatively depending upon the procedure that we perform. In the early post-operative phase, we do initiate hip range of motion exercises in order to prevent stiffness. However, we do avoid flexion beyond 90 degrees in order to avoid impact on the labral repair. The specific post-operative rehabilitation protocol that you will follow will be defined based on the specific procedure, the specific findings, and the specific procedure that you require. Anytime you undergo a surgical procedure, there are potential risks and complications. We make every effort to try and minimize your risk and to avoid complications, but nonetheless they can occur. I think it is an important part of your decision to understand some of the potential complications. First of all, anytime you operate, there's the risk of infection, and after hip arthroscopy, the risk is about 1%. Again, we make every effort to avoid this serious complication. Scar formation tends to be minimal. Typical hip arthroscopy requires 2 to 4 arthroscopy portals. Each portal is about 1 centimeter, and it may be necessary to use additional portals in order to gain the right access or the right angle of approach to the hip, but this is minimally invasive so that you won't have a lot of scar formation. Wound healing typically takes 7 to 10 days. The arthroscopy portals are relatively quick to heal. The deep healing is much slower. A delay in wound healing would be defined as a wound that hasn't healed by 2 weeks, and the incidence is about 3 to 5% for delayed wound healing. There's the potential for injury to nerve or vessel. With hip arthroscopy, the portals are made using what's called a nick and spread technique, where we make a small incision in the skin, we spread the subcutaneous tissue, and then, of course, we mentioned earlier using the dilators to create the portal. So we don't actually dissect out any small superficial skin nerves. As a result, about 15% of hip arthroscopy patients will actually have some numbness on the outer side of their thigh, and this can be permanent. Bleeding and bruising always occur. It's typically only an ounce or 2 of blood loss. It will not require a transfusion, but sometimes there is bruising, and the bruising can be extensive. It may track down the thigh and leg. The bruising gradually works its way to the surface over the first 4 to 7 days, and then it gradually resorbs over the next couple of weeks. DVT is a deep vein thrombosis. This is a clot in a deep vein of the leg. It's more common with open surgery, such as joint replacement surgery, but it can occur after arthroscopy. In order to try to decrease your risk for DVT, you will be on a baby aspirin daily for 6 to 8 weeks until you are completely off crutches. Also, getting up for frequent short periods to ambulate is helpful in decreasing your risk. You'll be educated on muscle exercises such as ankle pump exercises, which can also be helpful to decrease your risk for DVT. CRPS, chronic regional pain syndrome, is a rare complication. It is characterized by an exaggerated pain response. This is out of proportion to the usual and expected post-operative pain. Everyone has some degree of pain, swelling, stiffness, with decrease in range of motion, strength, and function after hip arthroscopy. However, with CRPS, these responses are significantly worse. This is associated with a prolonged recovery time and can negatively impact the final outcome. Fortunately, CRPS only occurs in 1% of hip arthroscopy patients. And then there's failure. The primary goal of the procedure is to relieve pain. It is less reliable for range of motion, strength, and function. In general, hip arthroscopy is successful about 75% of the time in improving or relieving pain. Unfortunately, that implies that 1 out of every 4 patients will fail to have significant pain relief. In the setting of failure to achieve our goal of pain relief, it may be necessary to undergo further surgery or revision surgery. Fracture is a rare postoperative complication that can occur, and the incidence is under 1%. Similarly, postoperative dislocation of the hip is a relatively rare complication as well, less than 1% as well. Instability can be there can be a sense of instability even without a history of hip dislocation. And finally, heterotopic ossification is abnormal bone formation in the soft tissue. And this occurs in 25 to 30% of patients. Without prophylaxis, it is significant, but if we use non-steroidal anti-inflammatory medications such as Aleve, 2 capsules twice a day, we can bring the incidence of heterotopic ossification down to about 5%. And finally, postoperative progression of arthritis. When we do hip arthroscopy, if there are arthritic changes, the arthroscopy does not address the arthritis, and the arthritis will progress over time. And eventually, it may progress to the point where further intervention is required. And if all of our efforts to preserve the hip and to relieve pain fail to give adequate relief, it may be necessary to consider total hip replacement. Now, you'll be given specific instructions regarding post-operative use of crutches, progression of weight bearing, range of motion restrictions, the use of cryotherapy, which is essentially the use of ice, because this can help with pain and swelling control. And you'll also be provided with medication for pain control. As I mentioned earlier, you'll be taking a baby aspirin daily to help prevent DVT or clot formation in the leg. And you'll be given a Aleve or a comparable non-steroidal anti-inflammatory medication for HO, which is the heterotopic ossification, which was the bone formation in soft tissue, for prophylaxis. Physical therapy will be arranged, and therapy is particularly important in the first few months. And although that's the main rehab time, people do have improvement after hip arthroscopy for up to a year. Hopefully, this information has helped to answer some questions that you may have, but it may have also generated additional questions, and I'd be happy to answer them for you. Thank you.